Okay, good morning. My name is Mike Pompliano. For those of you that don't know me, I'll be talking about degenerative spondylolisthesis this morning. Feel free to stop with any questions, kind of a big topic, so I'm going to jump right in. So there's 6 subtypes of spondylolisthesis that we classically talk about: dysplastic, isthmic, degenerative, traumatic, pathologic, and post-surgical. You can see here that we're going to talk about the degenerative one, which is degeneration of the facet joint complex, specifically the capsule and ligaments with an intact pars. This is our overview for today. A little bit of the history and background. Spondylolisthesis comes from the Greek word spondylos, which means vertebrae, as well as olisthesis, which is falling or slippage. It was originally described in 1782 out of the obstetric OB literature by a Belgian obstetrician. First described from lumbosacral dislocation during delivery, or an obstruction during delivery, excuse me. Then Killian in 1854 coined spondylolisthesis. It was later clarified in 1950 as the degenerative variant with an intact pars by Ian McNabb. The exact definition is an anterior-posterior translation of one vertebra over the subjacent one. It's associated with degenerative changes without a disruption or defect in the vertebral ring. It's classically defined as 3 millimeters or 5% slip, which we'll get into shortly, the paper where that originated from. There's a pretty common pathogenic degeneration cascade. You get disc degeneration, ligamentum laxity, and/or sagittal facet orientation, which is a risk factor for the disease, which leads to narrowing of the disc space, settling of the vertebral segment, and an increase in intervertebral segment motion. And then subsequently, you can have sclerosis, instability, facet hypertrophy, and ligamentous hypertrophy and buckling. And all of these may lead to secondary stabilization, but are commonly associated with spinal stenosis, which you can see there. Spinal stenosis is also one of the big presenting factors that we'll get into. Typically, this is seen in patients greater than 50 years old. Females much more common than males, about 5 to 6 times the rate. Black women are 3 times more frequently affected than white women. It's most common at the L4 to L5 level, which is in contrast to isthmic spondylolisthesis, which is typically L5 to S1. As a result of the intact posterior elements, slips rarely exceed 30%, and they can be commonly asymptomatic, but when presenting, they typically present with spinal stenosis. This is an epidemiological study from 2007 looking at 4,000 patients aged 22 to 93, the majority women. The prevalence was 6.3% in total, again, much more common in women at 8.4%. The average age was 68 for men and 71 years for women. Significant factors associated with the disease for men was age. For women, it was age, BMI, height, weight, and lumbar lordosis. However, they found no association with smoking, heavy lifting, seated occupation, age of menopause, or pregnancy. As far as risk factors for the disease, one risk factor is transitional anatomy, which increases the rigidity at L5 to S1, causes increases mechanical loading on L4 to L5. Also, pregnancy and oophorectomy can cause the disease. It's believed to be related to a transient or permanent decreased estrogen load, although the exact cause is unknown. Generalized ligamentous laxity, diabetes, which weaken the collagen cross-linking, and then the 2 big ones that play a role in our patients are sagittal facing facet joints, which is asymmetry between the left and right, as well as an increased pedicle facet angle, which allows for increased subluxation of the inferior facet joints. This is a meta-analysis from 2017, including 17 studies, which showed that spondylolisthesis patients had more sagittally oriented facet joints compared with their control subjects by approximately 10.5 degrees. They also had more facet joint tropism, which is the asymmetry between the left and the right joint, which was 1.84 degrees more. This is a retrospective review from 2007, which showed 40 patients with degenerative spondylolisthesis compared to 154 controls. They found that pelvic incidence was significantly greater for the patients with degenerative spondylolisthesis. And then after matching for the pelvic incidence, they found an anterior translation of the C7 plumb line, loss of lumbar lordosis, as well as decrease of the sacral slope. And then they also noticed that 30% had compensatory retrolisthesis in the upper lumbar spine. As far as clinical features, I talked about the common presentation being spinal stenosis. Primary symptom in that is going to be pain, 94%, and then numbness and weakness as second and third. Back pain is by far the most common complaint, but you can get L5 radiculopathy secondary to the compression and the lateral recess. You can also see neurogenic claudication, which is pain, paresthesias, or weakness associated with walking and standing, as well as lower extremity symptoms and even bowel or bladder symptoms, although that is rare. You can get night leg cramping or fasciculations, and then on exam, typically improved symptoms with flexed posture, similar to our other neurogenic claudication patients, as well as hyporeflexia and L4 or L5 specific findings. On radiographic analysis, typical workup will include standing AP and lateral radiographs with or without flexion and extension views, and then as well as evaluation with the supine MRI. The Myerding classification can help classify the degree of slip, though it may not necessarily lead, like some classifications, as far as guidance with treatment. Typically, grade 1 is 0 to 25%, and then each quartile increases a grade until grade 5, which is if it falls off the sacral end plate. Or sorry, in this case, typically the L5 vertebral body. You can also measure a patient's pelvic incidence, sacral slope, and lumbosacral angle, which can give a better understanding of their global alignment, as well as their propensity for instability and increase of the disease. As far as specific findings with flexion and extension radiographs, this was a retrospective review of surgical patients with grade 1 spondies compared MRI to upright X-ray. Additional motion was defined as 3 millimeters or more, slip difference on flexion and extension views. They found in 191 patients, assumed 7 millimeter slip or 4 or more required fusion, and then 31% had additional motion on the flex X views that was not seen on the upright MRI. Of those 31%, 19 had slips less than 7 millimeters on upright X-ray. So if you assume that their assumption is correct with the 7 millimeter slip requiring fusion, basically 19 of the 191% or around 191 patients, or around 10%, had utility from the flexion and extension views. This was a paper looking at lumbosacral segmental motion in normal individuals, and is one of the papers that helped identify the 3 millimeters of translation. They found that 90% of asymptomatic volunteers had 1 to 3 millimeters of translation on the flex X views, and then they postulated that dynamic change greater than 4 millimeters was therefore considered abnormal, which helps guide our treatment today. As far as lumbar facet joint effusions on MRI, this was a retrospective review of 160 patients. They with partial reduction on supine MRI, leading to facet joint distension, which could then be quantified and used to assess instability. 108 patients, or 67%, had large facet joint effusions, which was 2.2 millimeters in their study, with greater than 3% slip difference from X-ray to MRI. The size of effusion was correlated with the percent change, which you can see in the graph on the bottom right. And then the extent of the left-right difference was also associated with the presence of a rotational translation. So overall, pretty good evidence that the facet joint effusion size can correlate to the degree of instability. Other radiographic analysis features that will suggest instability are facet fluid, synovial cysts, interspinous fluid, facet joint hypertrophy, and the vacuum phenomenon, which you can see there from A to E, examples of each. Getting into the natural history a little bit, this is a study out of Japan, looked at 145 non-surgical patients, examined for 10 years. 110 had no neurodeficits on presentation, while 35 did. They found progressive spondylolisthesis in 34%, but no correlation in the clinical symptoms or progression of the spondylolisthesis. Disc height decreased significantly for patients who did not progress, which may indicate some degree of stability. 90% of patients with disc height loss experienced improvement of low back pain, which again may lead to further evidence of stability eventually occurring through the sclerosis and decreased disc height. 25% of asymptomatic patients had progressive neurological decline, which may be helpful in counseling our patients as they present and decline surgery. 83% of patients with neurologic symptoms at presentation declined over time, showing that they were at higher risk for neurologic decline than asymptomatic patients. As far as conservative treatment options go, it's pretty standard with the rest of our lumbar spine practices: anti-inflammatory medications, activity modifications, weight loss, physical therapy, core strengthening exercises, epidural steroid injections for symptomatic control, diagnosis of management of osteoporosis to prevent further decrease in bone health. Uh, with respect to weight loss, this was a prospective study on morbidly obese patients looking at their disc height after bariatric surgery for weight reduction. Patients were measured both pre-op as well as 1 year, and they found a 2 millimeter increase in L4-5 disc height from 6 to 8 millimeters. Both axial and radicular back pain decreased markedly after surgery, as well as no correlation between the rate reduction and the increment in disc height or back pain improvement, but this is still pretty good evidence that weight loss can actually improve symptomatic control, and it's not just something we talk about frequently. With respect to physical therapy and epidural injections, prospective randomized trial of 29 patients followed for 6 months, broken down essentially into 3 more or less equal cohorts, 10 PT, 10 epidurals, and 9 controls. To me, there was somewhat of a confounding factor in this study in that every patient received diclofenac and a home exercise program. So with respect to PT versus home exercise program, there's still some therapy involved. They did, however, find similar significant improvement in the physical therapy as well as the epidural steroid injection group in both pain and functional parameters. And their parameters were treadmill walk tests, sit to stand, and weight carrying test. They also found significant improvement in the control group, but less than either treatment group. So therapy and epidurals had overall better improvement than just the control alone. Subset analysis from the SPORT trial, 192 degenerative spondylolisthesis patients in the no epidural steroid group and 74 in the epidural steroid group. They found no difference in surgical rates over 4 years between the two. The surgical epidural and no epidural groups showed no difference in outcomes, and then the non-op no epidural group showed greater improvements than the non-op epidural group. However, they did have crossover rate between the surgery and non-op groups, and we'll get a little more into the SPORT trial shortly. So like many of our other procedures, treatment goals are pretty similar. One thing that is kind of specific to degenerative spondylolisthesis, or at least is a big factor to consider, is neurologic decompression. Like I mentioned earlier, a lot of our patients can present with symptoms of spinal stenosis, so either central or lateral recess compression, and can also have lateral recess, foraminal compression as well. You also want to make sure that you're getting good stabilization of the segmental instability, because this is a translation of one vertebral body on the other. You want to make sure that you prevent any further slip. And then you also want durability of outcomes. So you want patients to get better and stay better across time, as this is a progressive disease. And then this is also a segmental kyphotic deformity. So you want to correct the deformity both at the acute segment as well as keep in mind the global alignment and make sure that you're not causing or that you are fixing any global deformity that's present. Surgical indications are similar to other diseases that we treat, symptoms that are debilitating and recalcitrant to non-surgical management, specifically with respect to radicular pain and neurogenic claudication. Patients who present with bowel and bladder dysfunction or progressive weakness should consider urgent surgical intervention. So a couple historical papers to start us off on the surgery overview. Decompression versus non-instrumented fusion in degenerative spondylolisthesis. This is a study from Herkowitz that looked at 50 patients, 25 fusion and 25 decompression, looking at posterior lateral fusion versus laminectomy alone. Follow up with 3 years. Patients that underwent laminectomy and arthrodesis had significantly less leg and back pain, as well as a higher proportion of good to excellent overall clinical results. They did find a 36% pseudoarthrosis rate, which is a common theme throughout some of these studies, but there was no clinically significant difference. Instrumented versus non-instrumented fusion. This is 76 patients evaluated by Fishgren, randomized to instrumented or non-instrumented single level with 2-year follow-up. At a minimum follow-up of 2 years, instrumented fusion had a significantly higher fusion rates, but there was no significant difference in outcomes. Again, kind of consistent with the last study. It is important to note that both of these are shorter follow-up with 3 and 2 years. Fusion with respect to pseudoarthrosis, 47 patients, single level degenerative spondylolisthesis, posterior decompression, and posterior lateral fusion. This is a longer-term follow-up with average follow-up of 7 years and 8 months. And then in patients undergoing single-level decompression, posterior lateral fusion, a solid fusion improved long-term clinical results. So you can see on the right there, solid versus pseudoarthrosis, and then excellent outcomes, 54% in the solid fusion group and 28% in the pseudoarthrosis. And then if you combine excellent and good, the difference is even greater. So getting into the SPORE trial, which is very important for this topic, it's 13 clinical sites, heavily funded by the NIH, each trial with two different branches, randomized and observational cohorts, primary outcomes assessed using the SF-36, bodily pain map, and physical function scales in ODI, as well as secondary measures including patient reporting improvement and satisfaction. In this Degenerative Spondylolisthesis arm, there's 304 randomized control and 303 observational cohorts. High rates of crossover in the randomized cohort, so it can be difficult at times to withdraw findings from this study. 36% of the surgical evented cohort elected for non-op treatment, and 49% elected to undergo surgery at 2 years. So the intention to treat analysis unfortunately didn't show a significant difference. However, if you look at the as treated analysis, there was statistically significant differences across all primary outcomes, strongly favoring surgical treatment at 2, 4, and 8 years, although the difference did decrease with time. Reoperation rate was about 20% at 8 years, 54% within 2 years, and then 45% was due to late complications, 36% due to acute local wound complications. They did note factors associated with reoperation were increased age, advanced stenosis, predominant back pain, lack of neurogenic claudication, no physical therapy, and higher leg pain scores. Most of those make pretty intuitive sense. I know we reviewed this paper the other day with Journal Club, so I'll kind of briefly go over it, but it was a randomized control trial with respect to spinal laminectomy versus instrumented pedicle screw, the SLIP trial published in 2016. 66 patients with stable grade 1 degenerative spondylolisthesis randomized to laminectomy or laminectomy with posterior lateral fusion, and then 2-year follow-up for the SF-36 and ODI score. Follow-up did decrease over time, specifically from 2 to 4 years. It decreased from 86 to 68%. They found more blood loss, longer hospital stays, longer OR times in the fusion groups, but no difference in the complication rates. The fusion group did have a greater increase in the SF-36 score at all endpoints, 2, 3, and 4 years, but the ODI was not significant, although it did trend toward the fusion group. It just missed the cutoff for the clinically significant. Cumulative rate of reoperation was 14% for the fusion group and then 34% for the decompression group. This is a study out of the New England Journal of Medicine looking at decompression versus decompression and fusion from 2016. They looked at 247 stenosis patients, 135 had degenerative spondylolisthesis. Of those, they were evaluated for decompression alone versus decompression and fusion. Primary outcomes were ODI VAS score, 6-minute walk test. They found no difference at 2 and 5 years. However, they did note greater OR time, more blood loss, greater length of stay, 4 versus 7 days, and then also greater initial hospital costs for the fusion group as expected. That was noted to be $7,000. There's no difference in reoperation rate between the two. With respect to fusion, looking at the addition of an inner body, essentially this adds 360-degree support and allows for fusion or potentially greater fusion of the anterior column. So significant benefit of increased stabilization, improved fusion rates, improved sagittal balance, as well as increased indirect decompression. Comparison of posterior lateral fusion with and without posterior lumbar interbody fusion. 40 patients, 2 years follow-up, broken down into 4 groups, both stable and unstable with respect to posterior lateral fusion versus posterior lateral fusion and posterior lateral interbody fusion. And then they compared stable to stable and unstable to unstable. They found that the interbody fusion had better ODI and VAS improvement, and the slip angle increment was increased between the stable groups, as well as the disc height increased between both the stable and unstable groups. So kind of providing evidence for some of the theoretical benefits we just talked about. Another study looking at posterior lateral fusion and interbody fusion. This meta-analysis included both isthmic and degenerative spondylolisthesis, looked at 8 studies, 723 patients. They found interbody fusion had better clinical outcomes and a higher fusion rate, although there was no difference between postoperative complication rate and blood loss. Looking at lateral interbody fusions with or without percutaneous screws. This is a study out of China from 2021, 95 patients, low-level spondylolisthesis, grade 1 or 2 at L3, 4, and 4, 5. They had 54 standalone and then 41 that opted for percutaneous fusion as well. Is a little weird because they allowed patients to elect their treatment after informed consent. However, either way, they did find standalone lateral interbodies had shorter OR time, shorter bed rest time, less intraoperative blood loss, lower post-op CRP and CK levels, which they postulated was markers for tissue damage, as well as greater improvement in post-op VAS ODI. And then they did note that 6 patients, or 11%, had to go posterior, had to add posterior instrumentation for subsidence. The percutaneous screw did improve radiographic parameters with both anterior and posterior disc height, as well as improved segmental lordosis, and had significantly less subsidence, as well as significantly lower revision rates. With respect to global alignment, this was a study looking at, or study of 84 patients with 3-year follow-up looking at LAMI and posterior lateral fusion for stenosis, not for sagittal malalignment. They, however, retrospectively divided into greater than or less than 50 millimeters of SVA and compared outcomes between the two groups. 46% had an SVA of less than 50 millimeters or 5 centimeters, so it was about 50-50. And patients with greater than 5 centimeters of global sagittal malalignment had a worse SF36 score, ODI, and more back pain, as well as more often had PIL mismatch. Multiple levels of degenerative spondylolisthesis, as well as the L3-4 level being involved, and multi-level fusion were more common in that group as well. With respect to reduction and the obviously a hotly debated topic about whether or not it's needed, typically this can apply more for isthmic spondylolisthesis, where some of your slips may be a higher Myerding grade versus the degenerative spondylolisthesis, which are typically low level. This was a prospective cohort study out of Germany in 2019, looking at 62 patients, low-grade degenerative spondylolisthesis with a single lumbar segment. They used posterior lateral interbody or transforaminal lumbar interbody. They found a significant reduction in anterior displacement, did not correlate to clinical outcome, and no change in lordosis expected pre to post operatively. So as far as summary of kind of the whole talk, always get standing AP and lateral lumbar radiographs as compared to supine imaging. Supine radiographs may fail to detect the slip. If patient presents with neurologic symptoms, they tend to progress more than asymptomatic patients, although both have a propensity to progress. In general, surgical treatment is decompressive laminectomy and fusion, and the role of interbody is still being more closely studied, although I think most people now would go ahead and include interbody due to the additional benefits that we discussed. Long-term surgical outcome appears better with the solid arthrodesis than a pseudo-arthrodesis, although that may not be present on short-term studies. And then posterior instrumented fusion produces more solid arthrodesis than non-instrumented fusion, which gets to the point about durability of surgery. Decompression without fusion may be a better option in select elderly patients with significant medical comorbidities and limited activities. You'll note a lot of the studies that we discussed showed greater blood loss or kind of perioperative complications, not necessarily long-term improvements of just the decompression group. And as always, keep the surgical goals in mind, neurologic decompression, stabilization, segmental instability, as well as durability of outcome, getting better and staying better, and then correction of the deformity, keeping global alignment in mind. That's it.
Mic drop.
John, what a huge topic.
So if you look through that literature, there's obviously variance. How do you discern amongst the different papers as to when you operate and when you don't in terms of fusion versus decompression?
I think a lot of it depends on kind of patient-specific factors. So one is obviously age and if it's an elderly patient and, obviously if they can't withstand some of these medically complex procedures, they either may benefit from decompression alone or they may benefit from just a, minimally invasive interbody. If I guess getting even before that, if their symptoms should be the primary factor determining surgery versus not surgery. So if they're having recalcitrant symptoms of stenosis, obviously that would lead more towards the surgery side versus if they can be well managed with epidural injections, weight loss, physical therapy, some of the conservative therapy treatments. And then kind of the anatomic factors we talked about, sagittally oriented facets or asymmetry between the two can help guide treatment as well.
Presumably they're in your office because they failed non-surgical stuff, right? So the hard part is deciding what to do. Do you decompress them? Do you fuse them? You think age and those factors are big factors or small factors in that? I mean,
I think they're
really the stress of surgery is the anesthesia, not what you're doing surgically. You're usually working at one level. There's not much blood loss, so it should be more an issue of just deciding what's going to submit that patient to the greatest risk of more surgery, right?
Yeah, I think those factors are only significant if present, if that makes sense. So obviously, the vast majority will be able to tolerate surgery well and are medically stable enough for it. And then it just comes down to other patient factors like any global malalignment that you want to address. Do you need the anterior support? I think most commonly that's being done nowadays, although it's still being studied, the exact utility and kind of the cost benefit analysis of that. But I think that there's certainly a role for it with both the deformity correction, the indirect decompression, and the anterior stabilization.
I'll ask you another question. Everybody else is quiet. When you see studies that assert that there's not a clinical impact for alignment and reduction and things like that, how should you look at that methodologically speaking with respect to their studies? Are the studies, I'll give you a hint, what's the duration of the study in terms of clinical or cost effectiveness and utility scoring?
Yeah, I think a lot of the studies have limitations and some of them can be pretty drastic. To your point, many of them are not certainly long-term follow-up. We saw that earlier with the 2 versus 7 year taking a while to be clinically significant, especially with some malalignment. And then also a lot of the studies, there's not good homogeneity between patients and many of them don't even report, that homogeneity. So there can be different patient factors, different presentations. Some of them did isolate specific classifications and grades of slips, but there can be a wide range with respect to that, with respect to the patient factors like the facet orientation and their independent risk factors. So it's really hard to capture all of those in the studies, let alone to have a study long enough to where that may play out with time and become actually significant.
Yeah, I would caution you a little bit. And a lot of our literature is limited both in numbers of subjects, right? So limited power. So when you see somebody say, well, there's no difference, check the messenger, check the follow-up duration and see if it's really long enough to prove out that point. And the power of the study. If you have 68 patients in a study, chances are you probably haven't generated enough power if your claim is there's no difference. If you see a difference, that's obviously all you needed. But if you don't see a difference and you have a small subject number, it should call the study into question a bit in terms of conclusions.
Yeah, I don't know the exact answer for this one, but it is interesting how different healthcare systems produce data that seems to be kind of with different goals in mind, either non-operative or operative treatment. So a lot of these studies weren't from the U.S. necessarily, from Japan or Europe, and it's just interesting how they seem to find different outcomes.
Yeah, there's definitely a cultural piece. Can you hear me now, by any chance?
Yeah, we can hear you.
Okay. Yeah, I think there's definitely a cultural piece that you have to interpret, which is important. I would even say there's probably even regional pieces, right? Because if you treat, someone in San Diego, it's probably gonna be different than treating them in Wichita, Kansas. Just if you look at patient demographics, just that alone. Hey, did you run across anything with like endoscopic surgery and spondies? Just out of curiosity.
I
Makes
did
me
not.
wonder that in leg pain heavy or neurogenic claudication heavy populations, if we're gonna see like like truly minimally disruptive operations like endoscopic surgery becoming a little bit more mainstay, in patients that are able to tolerate the slip. In other words, maybe if you're able to treat the neurologic elements in isolation.
Yeah, I
Okay.
didn't come across anything on that, and it's a little bit of a cop out, but I'd imagine it's like everything else. For the right patient, it has a good utility. There's also you don't really lose anything as far as just decompression goes. It does make sense that if you don't fix the malalignment, you're still you're not necessarily fixing the biomechanical forces, but if you just proceed with decompression initially, you can always do a fusion later. So it's an interesting thought. It may have some role.
I think it was a great talk, Mike. I obviously being new into this, see a lot of patients come in with, a spondy that's usually stable and neurogenic claudication or some sort of stenosis, and this is the hard part of the job, right? And so it kind of comes like with knowing all that information and kind of looking for, certain things on imaging, and then just talking to the patient, getting their whole story. So it's this is the confusing part, and that's why you have these guys to kind of ask and lean on and be like, hey, what would you do? So that's good. It's a good summary of everything.
Yeah, it was funny. I would find one study that said one thing and then immediately come into another that said the opposite. So it's definitely a confusing topic. Lots of ways to apply
It usually means that we don't know, right?
Yeah, I'll add to that, Stephen. I think the key take home from that literature is that the studies are limited. And there's actually a group of people that you do want to be thinking about decompression, and then another group you do want to be thinking about fusion, and you shouldn't be hook, line, and sinker one direction or the other. So if you see a spondy in clinic going forward, if you fuse every one of them, you're probably doing the wrong thing. If you decompress every one of them, you're probably doing the right thing. And our literature hasn't gotten to the point where we have the granularity to figure it out. So some of it's experiential, but you're learning all those things to sort of guide you, which are the facet tropisms and the change between standing and laying down and the dynamism of their symptoms. And you've probably seen us get CTs to see if the facets are ankylosing or starting to lock down, or that over time spondies tend to ankylose. So all of those features are important to factor in, and you can't be universal in your application. If you are, you're doing a disservice to some of your patients. And if you find a sort of sweet spot in between, you probably do more good than harm.
Yeah, that's a great summary statement, Bob. And I especially want to underscore the positionality of it. I mean, we know that's absolutely huge because a lot happens from, being supine for an image and standing. So please take that into account.
Nice job.
Uh,
Oh, go ahead.
Basically, everyone used FlexX film to help make the decision of fusion or not fusion. But I hadn't seen too much in terms of literature. Did you present anything on that, Mike? Did I miss it, or the use of FlexX films?
Yeah, so there was I only came across one study that essentially showed about 10% of patients will have instability seen on FlexX films. It's not identified from standing X-ray to supine MRI. So it does seem like that captures pretty much everybody. And then there was about 10% that the FlexX was an additional benefit in. Other than that, I didn't come across any other methods as far as determining instability besides just looking at the difference between standing and supine. And then also the facet joint effusions, larger effusion equating to increased instability.
Anyone else? All right, silence. We're good. Have a good day, everybody. Great job, Mike.